Well, good evening, everybody. Welcome to our Frankly Speaking about chronic blood cancer. We are very thankful for Dr. Joe Hoffmeister to be our presenter for this program. This program is being recorded tonight. So if there's any questions that you may have, or if you miss something, you'll be able to go back and review that. As Dr. Joe is going through the presentation and you have questions, feel free to unmute yourself and ask those or put them in the chat. We'll be monitoring the chat as Dr. Joe is presenting. So Dr. Joe, welcome and thank you so much for being our presenter.
You're more than welcome. So just a little bit of background on me. I've been in practice now 21 years and practice at Columbus Oncology and Hematology Associates. I also have a company called Dr. Joe Explains, which really focuses on patient education, trying to bridge the gap between patient and providers, and is one of my missions, which really has drawn me to the cancer support community mission as well. And I really like how they focus on cancers and how they present patient education. So we'll get going. This is just a statement. This was created by Dr. Cami, and then I did edit their original slides pretty extensively to try to make it a little bit more focused. This was created by a cancer support community. The content was developed independently and outside of medical and psychosocial experts. It is controlled completely by the cancer support community, Central Ohio and national. I don't have any conflicts or financial relationships with the companies that are supporting this talk. So what we're gonna work on today or look at is we'll go over what leukemia is. We'll focus on CLL and small lymphocytic lymphoma, and then CML. We'll address the symptoms and diagnosis of how these conditions present. We'll briefly talk on treatment options. I was going to stay probably more away from the treatment options specifically, just because there's so many and they change by the day. But we'll briefly go over that, address some clinical trials, and then living with CLL and SLL and CML. So this is a slide to really kind of empower patients, and patients have been diagnosed with cancer. Doesn't really mean that the cancer needs to control you. How you accept the diagnosis is typically through education of yourself, helping to get support and have hope and courage for the future. We like to say, cancer really happens. Nobody chooses to have cancer develop, and regardless of your previous choices, it's not really a choice. It happens. So what is chronic lymphocytic leukemia? It's otherwise known as CLL or SLL, and SLL is small lymphocytic lymphoma. And I'll get into more definitions in those regards that sometimes can be very confusing. We'll look at key terms, prevalence of the disease, or how common, symptoms that patients may develop, and then kind of how we diagnose it. So CLL stands for chronic, and the reason it is chronic is because this is something that typically takes a long time to develop and or worsen. It's lymphocytic is the type of white cell that is the cancer-related cell, and so it's called lymphocytic. So it's one of the type of white cells that we deal with. Leukemia just means that it circulates in the blood, so you can detect the malignancy in blood. These are most commonly, or by definition, CLL is B lymphocytes or B cells. Need to hide my sorry, I needed to hide my videos. It was covering my slides. And these B cells are part of the immune system, and they're used to really make antibodies and to help protect people against bacteria, viruses, toxins. Vaccines, today are part of the stimulation of the immune system with lymphocytes. The other major types, which we'll talk about, is chronic myelogenous leukemia, And again, a chronic disease. Myelogenous is the type of cell, so it's a different type of white cell. And then the other two is acute lymphocytic leukemia, or ALL. Acute meaning these typically come up over weeks to a few months and are highly, highly aggressive and really cause significant difficulty quickly. And then the two types are, one is a lymphocyte malignancy, the other is a myeloid. And these are, again, two different types of white cells. So small lymphocytic lymphoma is the same cell as CLL, except when you discover it in a lymph node. So if you don't have cells circulating in the blood, which would designate it as leukemia, and you have a lymph node biopsy instead, the pathologist will call it SLL for small lymphocytic lymphoma, lymphoma meaning in the lymph nodes, CLL in the blood. But these are the same disease, essentially, and they are treated as essentially the same. How they show in the body is different. In CLL, cancer cells are in the blood, the bone marrow, spleen, lymph nodes, and can go to other organs. SLL is essentially found again in lymph nodes. So CLL is typically a slow-growing condition, and it will continue to increase in size. The mechanism of this malignancy and how it accumulates is that the cells typically just don't die. So most cells in the body undergo what they call apoptosis or programmed cell death, and the cancer's normal cells will live only so long and then die, and then they get repopulated with other cells in some organs. In CLL, these lymphocytes gain changes that allow them to continue to live indefinitely, and they don't die on their own. A couple of things of why it's slow growing is because CLL for many people don't need treatment right away, and some even 20 years later will never need treatment. Other people have CLL that can grow more quickly, and they can have more advanced disease or more symptoms related to their CLLs. Those patients who have a fast-growing version, or it's causing problems with lymph nodes or other symptoms that we'll talk about, may require treatment much sooner. Eventually, most patients will require a treatment at some point. The treatment paradigm is changing from kind of using chemotherapy and immunotherapy, which is used typically for a fixed period of time, and then stop and wait, where targeted therapy now is becoming way more popular, and targeted therapy is typically used continuously. There are newer treatments now looking at combining different drugs that might give us drug holidays again for CLL. Currently, outside of an allogeneic transplant, there really is no cure for CLL, but CLL also doesn't cause a lot of problems for most patients for long periods of time. And so it can a lot of times not impact patients' lives initially, and then hopefully the treatments would be something you can tolerate. So we kind of like to say people live with CLL. So a couple of the words that I use or other doctors use in their appointments, and kind of the key ones again, are chronic, which is long-standing and not acute, leukemia, meaning circulating in the blood. Lymphocytic is the type of white cell that fights infection, and it's a B cell subtype. They come in B and T, and then there's a variety of other type of white cells. Blood counts is another term you'll hear, and that's a CBC. Could be a differential, which tells kind of what type of white count. A bone marrow is where the blood cells live inside almost all the bones, mostly in the sternum and in the pelvis. Anemia is where the red cell count is low, and that can be represented by hemoglobin or hematocrit, is the two other terms that we look at that say that you're anemic or not. Thrombocytopenia is platelets, which are the clotting cells, and when they're low, we call it thrombocytopenia. High white count, or WBCs, is what we find in the blood count that really leads to the diagnosis of CLL. So how common is it? It's really the world's most common leukemia, and it is about 21,000 cases per year. It's not rare by any means. It's not the most common. To give you an example, lung cancer is about 180,000 patients per year. Breast cancer is about, depends on statistic, but about 180,000 as well. The average age is typically 71, and there's some variation around that. Some are older, some are younger. It's pretty uncommon under 40, and very uncommon in children. So how do people present with CLL? I would say the number 1, 2, 3, 4, and 5 is that they get a blood count with their primary care, and they have an abnormal blood count or an elevated white count, and the lymphocyte count is elevated. And I would say that probably accounts for 80+% of patients. They can have other associated symptoms, and one of the more common way patients find it is if they have a lump or a lymph node or a gland that's enlarged, typically neck or under the arms, can also be a sign of CLL. So just because it's in the blood doesn't mean it can't be in the lymph nodes as well, which is actually pretty common. Other findings that can lead to the diagnosis or cause symptoms from CLL is a low blood count or anemia. Can have a low platelet count, which can make people short of breath or have some bleeding tendencies. The lymph nodes or glands I talked about. The spleen is located, and that's a typo, it's in the left upper quadrant, not the right, and can give you fullness when you eat, kind of some swelling in the abdomen. Tiredness and fatigue. Weight loss is rare from CLL unless it's advanced or converted to a much more aggressive form of lymphoma. Drenching sweats also, and fevers for that. Now, infections are very common in CLL. The immune system does not work correctly, and so infections actually is one of the most concerning aspects of patients with CLL, and so we try to treat those very quickly and early with any signs of infection. In the world of COVID, vaccines may be less effective in CLL, but are highly recommended to be administered, given that patients with CLL are going to be at higher risk for complications from infections. Autoimmune diseases also can occur, and they can occur by attacking the blood cells and or other parts of the body. Most of the time, though, when I see somebody newly diagnosed, at least, other health problems like thyroid can cause fatigue, or as other things related to the CLL. So a lot of times, again, this is found just on a routine blood test. So how do we diagnose it? We do a blood count, and there's a lymphocytes portion on the white count that we look at, and those, what we call absolute lymphocyte count, has to be greater than 5,000 of these malignant cells. And it gets a little tricky. You have to actually keep moving the target, but you have to define that based on a very specific test now to say you have more than 5,000. But if you're looking at your white count, and your white count's 20,000, and you have 12,000 lymphocytes, you're pretty likely going to have CLL. There is a benign condition that I think can be quite confusing, and it's called a monocytic B-cell lymphocytosis, or MBL are the initials for it. This is benign. It's when we do this special test, we have less than 5,000 cells when you do it in the blood. It is a condition that we do monitor, and for some patients will progress on to CLL. In my mind, it's a little bit less important, because if you have only 5,000 or 10,000 lymphocytes and versus 4,000 lymphocytes, and you don't have lymph nodes or other symptoms, essentially they're the same. It just means it's a little predictive that the ones less than 5,000 won't really have the white count elevate quicker. The confirmatory test is flow cytometry, in which we can really pull these cells out, count them, get very specific tests to diagnose it. There are variants to CLL, so not all of them line up to CLL, but CLL is the most common. Bone marrow biopsies are not typically performed for CLL. We can typically diagnose this through the blood. And then there are gene tests or FISH tests, which better define risk populations. These risk populations are becoming less important, secondary to the treatments being really effective for most patients. Okay, I'm going to stop there and see if anybody has any questions. Nope. Okay. Silence is golden.
Yeah, and there's nothing in the chat.
Okay, thank you. So CML, I'm going to kind of go through this quick because we have a very focused audience. Kind of the same things. There is some differences. It's chronic myelogenous leukemia, so the M is myeloid, and those are along the neutrophils, which fight bacterial infections specifically. It really is a bone marrow cell and can be in the spleen, but it's generated in the bone marrow. So bone marrow and blood counts are the more pertinent findings. There is a specific genetic mutation, which is called BCR-ABL. This is otherwise known as the Philadelphia chromosome. And this was the first real gene that led to targeted therapy or the magic bullet of cancer. So this is the prototype, or this is the first cancer or malignancy that we've developed a drug specifically to attack Philadelphia chromosome or BRCA-ABL mutation. And it's been highly, highly effective from being a fairly difficult disease to now a really well controlled, and some patients are now cured from what we learn after receiving the medications we'd give. Again, it's typically a slower growing cancer. More patients, though, I'd say would present with symptoms with this than a routine blood count, but routine blood counts, again, are a common way to diagnose it. So blasts are immature cells in the bone marrow, and that's where we look at that number to see how advanced CML is. Again, leukemia is found in the blood. Again, many patients are diagnosed through routine blood work, pretty much the same symptoms. I'd say weight loss, fevers, and sweats are a little bit more prevalent in CML, especially if you have a really high white count or an enlarged spleen. Here's the tests that we kind of talked about. And then again, it's chronic is the most common phase of which patients are diagnosed in. It's when we don't find early blast cells in the bone marrow. Accelerated is between what we call blast crisis, where this really is acute leukemia and a highly, highly aggressive disease that needs rapid treatment. Accelerated is the in between. So it's when the chronic is we're losing control of the chronic CML. We start seeing increasing blasts, big spleen size, and those patients are destined to go on to blast crisis. Sometimes you'll catch people newly diagnosed and accelerated, but in general, we catch them mostly in chronic. So I'm going to switch gears and just a couple of slides on communicating with your healthcare team. I do feel it's really important that you can trust your doctor who you're talking to, and that you feel comfortable with them. You should really feel respected and listened to. You should have time to have your questions answered. If you don't understand anything, hopefully your physician would then repeat it and kind of really try to explain your condition. Blood cancers are uncommon, and they're relatively rare. CLL is not. CLL is very common. CML is much less common than CLL. And seeing a physician like myself, a hematologist, oncologist, and or getting to a subspecialist at an academic center would be very, very reasonable choices. Second opinions are often helpful in these diseases, and for reasons which we'll get to here in a minute. I find that second opinions can be very helpful for any time for a patient if they have questions or additional questions, or just want reassured of the diagnosis and the treatments and things. So utilizing your medical personnel is helpful. So I'll switch over to treatment for CLL. And I think this is probably the biggest difficulty for patients, especially when they're first diagnosed, is what we can recommend is what's called watch and wait or active surveillance. And since CLL has slow growth and really can lay dormant for many, many years without causing any problems, we don't immediately treat it. And there's a couple of good reasons for it. The reason we don't treat it immediately is we've found that if patients start treatment today versus starting it down the road when they need it, we have not extended life for CLL patients with treatment. Part of that is difficult because patients live so long, so you need 20 years of a study to prove that something is extending something from 15 years to 16 years, and so you need really extensive time to prove survival benefit, is what we call it. And so they are looking at different markers for that, and research studies are exploring early treatment versus delayed. But currently, the way I kind of think about it is if it is not bothering you, we really don't want to bother you with treatment, because the treatment is going to make you feel worse than if you feel fine. If you have symptoms related to CLL, and those symptoms can sometimes be difficult to separate from other things, then treatment is definitely indicated, and it's highly, highly effective. So during watchful waiting or active surveillance, we typically will see patients different intervals, and kind of depends on where you are in the watchful waiting or active surveillance. In general, we'll see people about every 3 months, and then typically extend from there over time if the disease remains stable. If you have changes to your blood counts or lymph nodes that have increased secondary to infection or other things like that, you may need to be seen a little sooner. Lymph nodes are known to go up and down, especially with like vaccinations and really increased lymph nodes temporarily. But they typically will go down over a few weeks or months time. We do really kind of there for support to make sure that things aren't getting out of control. But again, early treatment does not extend life at this point. And I would encourage, if somebody really wants to go on an early treatment, to participate in a research study.
Dr. Joe, we have a question in the chat.
Okay.
Paula asks, you said COVID vaccines are very recommended for CLL patients, but less effective. Does this mean the patient should get multiple booster vaccines? If so, how often?
Yeah, so right now, CLL patients would be considered in the immunocompromised group of patients. So currently, depending on the vaccine, so J&J is one vaccine plus now a booster that's being administered. Moderna and Pfizer are both with 2 vaccines up front, and then they're recommending a booster for anybody over 65, healthcare workers, and anybody who's immunocompromised. And CLL would be in that group of patients who would be considered immunocompromised. It's a moving target with COVID for sure. So, influenza, we recommend the high dose vaccine for the flu. For COVID, it's a moving target. So right now we're at the 3rd dose for Moderna and Pfizer as recommended boosters. J&J would be 2. I don't know when a 4th dose will be recommended. My guess is this will be at least yearly injection, similar to the flu, but don't know that for sure. The antibodies that are made with a vaccine are similar to what fight infection, and that's why infection is really a concern for CLL patients. So you can do tests called immunoglobulins or IgG levels in the blood to see if patients are already low. It's pretty common for CLL patients to have low immunoglobulin, and we actually supplement that with infusions in some patients to try to help boost the immunity. But CLL patients are just known to be immunocompromised secondary to the lymphocytes not working and or suppressing the immune response. I think I answered it. Okay. Any other questions on that?
There's nothing in the chat.
Okay. So when you're, these are some tips for coping. Ask questions why we're watching and waiting, and is this the best choice for you? You should kind of be aware of symptoms that can develop with CLL, and if they develop, then treatment could be considered. In general, that treatment decision is not usually something that has to be made in a day or a week even. Sometimes we watch and see if lymph nodes will go back down if they're bothering you, or if there's other causes of how you're feeling. Kind of do a symptom tracker or kind of write down how you're feeling. And then you can, ask your doctor if they think or you think this is enough to really start treatment. The whole tough part is trying to live with it without trying to think about it. I think it's a way to kind of think if you have diabetes or pre-diabetes, really, can we do things to just kind of try to not need treated. And then really from our standpoint is really trying to just maintain good quality of life regardless, doing activities and trying to keep down stress. Fear is really, I think, very common, especially in the newly diagnosed patients. And this is where I think second opinion sometimes helps, where, I see a patient and I tell them they have CLL and they look at me like I'm crazy, that I'm not treating them. The typical response is, you just told me I have cancer and leukemia and you're not going to treat me. Like, what is that? You're crazy. But, with time, then they realize, well, good, I didn't need treated because I don't want the side effects of the treatment, and the side effects can be harder than the disease that isn't bothering you. So these are some of the symptoms that we focus on to kind of guide us with treatment to beginning. If you have lymph nodes or glands that are enlarging and bothering you, and again, they may fluctuate. If your spleen is getting big in your abdomen and making you full and just not feeling well. Fatigue is really hard, especially in the last 2 years, with COVID and COVID kind of anxiety and emotions. So fatigue is very difficult. Now, if you have anemia, that can lead to fatigue. And if you have that, then that becomes a much easier thing to recommend treatment. White count doubling time is a little tricky, but typically what this is if the white count doubles in a 6-month period, then that could be an indication for treatment. Low platelets or low thrombocytopenia can be an indication, typically less than about 75, typically less than 100,000, but a lot of people will wait a little longer depending on the cause. And then if it's isolated and there's other causes, you try to treat that first sometimes. Weight loss, fever, night sweats are usually a sign of a significant progression to a more aggressive cancer or a lymphoma, what they call Richter's transformation. Autoimmune disease is also another one. So we really take into a lot of different information. We look at imaging, and then we decide with the patient, and we decide together, is this the right time to start treatment, and then what kind of a treatment. If symptoms or blood counts are worrisome, then we will start treatment. It's not like we're avoiding to start treatment. We just don't want to cause problems if we don't need to. And again, most patients live with this, and many patients don't need treatment for extended periods of time. Through a lifetime, if patients live long enough, they will eventually need treated. And fortunately, now we have lots and lots of very, very good treatment. So what are the goals of the treatment? It's really to slow down the growth of the CLL. It's really to maintain your lifestyle and quality of life, keep you well enough to carry on daily activities, really to try to keep infections away, and then to try to maintain decent or normal blood counts. CLL, again, is not intended to get rid of it forever. If we find a curative therapy that is highly effective, then we may see a change in this recommendation to watch and wait, depending on the risk and the benefits of that treatment. So if we can find a curative therapy, then we would use it, and put people at higher risk for side effects if that's the right thing to do. But currently we don't have that available, and early versus delayed treatment keeps the same survival, and I never said that before. Let me see, I think I went ahead. So even after you do treat it and it's kind of not visible, it will come back at some point. How long it lays dormant is a different question, and the newer treatments are continuous treatment. I've already said that. And then so in addition to the watch and waiting, there are several different groups of different treatment. So targeted therapy has become really the newer standard in CLL, and there's several drugs that attack different enzymes to really create really good responses that last for quite a long time. Most of these drugs you have to stay on continuously, and the most talked about are what they call BTK inhibitors. It was actually developed at OSU in the initial studies. Immunotherapy, there's different kinds of immunotherapy, or otherwise known as biologic therapy, and these are antibodies that we use to target the cells. Immunotherapy is commonly combined with chemotherapy, or otherwise known, which is chemoimmunotherapy. Sorry, I'm going out of line. Targeted therapy can be combined with immunotherapy as well. And then every day there's new treatments that are being developed in clinical trials, and we try to have patients participate in these if they can. So the treatment schedule or the regimens can be a single therapy of drug, it could be pills, it could be IVs, it could be combinations, and it can be given repeatedly and or indefinitely. So each combination, each drug is given differently. So these are questions, I guess, to ask your doctor, and this is just to reassure that you feel comfortable. How much experience do you have treating CLL? I'd say most oncologists today and community academic are going to be very familiar with CLL. Does the insurance cover the cost of your care? A lot of times, especially if we use these expensive targeted treatments, we have patients to help try to figure that out. If you need IV, sometimes it'll be in the facility you're seeing your doctor in. Sometimes it's not. Some practices will have social workers. Oncology nurses are essentially standard, for an oncology practice, and they'll be available for support as well. And then other supportive services are really to help patients with their financial needs and other things like that. I would hope a practicing physician is up to date with treatments. Clinical trials change by the day. So you really have to be kind of looking for a trial at the time that you need it. And then, if you'd like a second opinion, I would say most physicians, myself, I never say don't get a second opinion. I guess the person who tells you not to get a second opinion strongly is the one I would go get a second opinion with. Is kind of my feeling. There are some people get a little more offended than others with second opinions. I kind of welcome them, and I want the patients to be as comfortable as they can with the doc that they're talking to. So when we look at CLL and treatment, we look at stage, and there's lots of different staging, but really it's low, intermediate, and high risk patients. We look at overall age and overall health and what we think patients can handle. We look at the blood counts. Are they high or low? Are they normal? We look at the white count. Depending on how high it is, we'll sometimes determine what type of treatments or other medications we have to use. P53 and deletion, 17p deletion, these are high risk CLLs, and those are really shown from genes that we test on the CLL, and this is part of the diagnostic testing. And these are still important because they do predict some resistance and really a quicker time to having problems. Fever, sweats, chills, again, are very worrisome, and we would want to know those. Molecular tests are also with this P53 and 17. And then there are many, many different treatments available after first-line treatment now. Currently, I would say most patients are using targeted therapy as initial therapy. Depends on really when you were diagnosed, if you need a treatment. But chemotherapy is combined with immunotherapy now, and it does work well, but it does have different side effects. The benefit of chemotherapy is that it can be used for a period of time and then stopped, and then just watch to see how long it will take for the cells to come back. Chemotherapy can be a little rougher on the body though, and will have a little bit more side effects. Most common, I would say, is bendamustine and Rituxan. So Rituxan is the immunotherapy. It's an antibody against what we call CD20, which is a marker on the CLL cells. Bendamustine is a older chemotherapy that they brought back and is highly effective. FCR is very aggressive. It's really only used for very young patients. Leukeran or chlorambucil and antibody treatment are also used. I'd say this is not used very often. The antibodies are, though. Targeted therapy, it really attacks like a gene or an abnormality in the cells with a drug that attacks a very specific part of it. And it can limit the damage to normal cells, because not a lot of normal cells will have the target that the drug is targeting. These are some of the drugs, and there's some newer ones that are coming out as well. Ibrutinib was developed at OSU and was one of the first targeted therapies. Calibrutinib is more likely also targeted therapy being used. These other ones are used typically in kind of second-line therapy. Vendiclass has good future development potential. It's also very good now, but it's much more difficult to administer. So I'd say most patients on targeted therapy are going to be on one of the first two, and then that can be combined with Rituxan or other antibodies. Immunotherapy, again, is the antibodies that attack the CLL cells. They're usually combined with other medications. Can be used alone rarely, but they're a little less effective than when they're used combined. These are the list of antibodies. Rituxan was the first one that was used. Gazyva is one that's used pretty frequently now in CLL as well. Stem cell transplant is not used very commonly for CLL. I'd say it's only for the patient who's relapsed and doesn't have many options. Allogeneic donor transplant is used again, but in a much younger population and highly refractory patients. And these can be, much more toxic than the standard treatment. Switching gears, so CML is a little different. So we talked about the Philadelphia chromosome, and we use targeted therapy there. Stem cell transplant was the standard prior to targeted therapy. Now it's a lot debated and used in patients who are refractory. Chemoimmunotherapy is also being used, and then clinical trials. So we kind of talked about the targeted therapy, and these are known as TKIs. This is the list of drugs that are commonly used, and there's now newer ones as well. I'd say Sprycel to Cigna are the most common used as first-line treatment now, with high response rates and very effective. Food can interact with these medications. Since nobody's with CML, we'll kind of move on from here. And stem cell transplant, as I said, it was used before, but not as much anymore. Move on from here. Interferon was an old drug that was the standard, and it's what we call an immunotherapy. It modifies the immune system, but is not an antibody. And then for CML, for CLL, we typically do blood tests. We feel, see if lymph nodes have shrunk or grown. In CML, we use specific blood tests that can really find that Philadelphia chromosome. And the idea is to really try to suppress it to where you can't detect any of these Philadelphia chromosome. Few caveats, there's you'll find some with low levels in normal patients that don't have CML. Clinical trials, let me stop there, see if there's any questions. Oops. Any questions before I go on?
There's nothing in the chat.
Okay. So clinical trials are really important for all phases of care for patients. Every drug that we use currently to treat really anything has already gone through a clinical trial. So patients in the past have, been participants in these studies to prove that one treatment is better than another and that they were safe to be given to patients. And so we try to enroll patients in clinical trials or encourage them to, so that we can continue to make cancer care better. Clinical trials are used to really test new drugs or new combinations of drugs and treatments. There's kind of three phases. Phase one is purely really experimental, just to see if it's safe and to find dosing. Phase two typically looks at a cancer type and really uses one treatment to see if it works. And then phase three compares typically a standard treatment to something newer. And then these can be given in a variety of different ways. Again, depending on the phase of the study, and they tell you what phase it is and they tell you the goals, is really your decision to participate or not. Placebos are also sometimes worrisome for patients, but typically a placebo is given in addition to a standard treatment. So the placebo is never used if we don't think there's a treatment that's good. And it's really the only way to tell if something is better than not. And you'd be surprised that occasionally the placebo is better than the study medication. So you need that placebo participating patient to prove if it's better or worse. Everybody hopes that it's better, but that's not always the case. And again, for CLL and or CML, there are trials that include newly diagnosed patients, and they're mostly looking at earlier treatment versus later treatment, and then which drugs to use first or in what order. Patients who relapse or don't respond to treatment, definitely I would encourage to use clinical trials. Patients don't tolerate treatments and need new treatments, that's another time frame. And then a patient who has persistent or relapsing disease, clinical trials I think are a very good option. So these are some questions you can ask. Am I eligible for a study? What's the study looking at? What are the benefits and risks to me? What do I have to do really to participate in the study? Are there tests or treatments? Well, I know if the treatments is standard or a new drug, and the answer is yes. They tell you what's being compared. And then, the side effects of the treatment, possible benefits of the treatment as well. And then costs, they clearly define what your insurance company will pay for, what the experimental arm is paying for as well. And then, the follow-up care for the study. In general, patients on study have a study nurse, and so they get a lot of attention. And again, really encourage patients to participate. See if any questions. Doesn't look like anything in the chat, but I can pause pause for a second. I'm gonna get a drink of water. All right, in the last about 8 minutes or so, coping with side effects. This is typically for for patients on treatment. The idea is that we inform you before you start the treatment, so then you can recognize the side effects of it. Chemotherapy is different than targeted therapy, which is different than immunotherapy, and they all have kind of unique side effects to each of them, and each of them require different potential treatment if they develop. So nausea is not as common with most of these treatments we've talked about today. Diarrhea is pretty common with the targeted therapies. Rashes can occur, constipation sometimes, blood counts and mouth sores can develop. A lot of the side effects that we have can be treated with medication, and or if we're aware of it. So kind of telling your doctor you are having side effects. The other thing I think people have is they fear telling side effects because they're afraid they're going to come off the medication or the dose is going to get reduced. And dose reductions in these diseases is not a bad thing. If your body can't handle it, the last thing we want to do is really push it to the limit with medication and side effects. These are the more common side effects of fatigue, infection, diarrhea, constipation, pain, inability to fall asleep, mouth sores, rashes, nausea, vomiting, low blood count, shortness of breath. Each of the drugs, though, have their own specifics. So like Ibrutinib and Calquence, they have atrial fibrillation, sometimes increased risk of bleeding. So each of them can have a different side effect than anybody. So just being aware of them is helpful, and then telling your doctors and your team to see if there's anything they can do about it. Breaks from treatment are also not uncommon with many of these targeted therapies. And then, this is kind of a way, I'm not going to go through all this, but this is a way to kind of summarize and or think about it, like how often does it occur? Does it occur rarely? Sometimes, all the time? Is it mild, moderate, severe? Is it new? Or has it been ongoing? Is it worse? So trying to get some adjectives around the side effect is helpful. And then these are a lot of the words that you might want to recognize and or tell your doctor if you experience them. And then again, how does it affect your life? Can be another kind of set of questions as well. And then one couple other slides, I don't have many more, but palliative care is commonly, I think, misinterpreted. So palliative care means really supportive care and or trying to improve quality of life. It's different than hospice care, which nobody likes to hear either of these terms, but hospice care is really in that transition toward end of life, where palliative care is really to try to help patients live the best life they can with the least side effects and least complications, as for improved quality of life. And so they really focus on supportive care, decreasing pain, stress. Anxiety, depression is a big part of palliative care, as well as pain control. And then, depending on your case and depending on what symptoms you have, a palliative care doc can be helpful. I can tell you in the community, they're hard to find, and it's a growing field, but we don't need more of them. And so a lot of the oncologists, do a lot of the palliative care needs. Again, hospice care is really for more transitioning toward comfort at the end of one's life. So, what can you do? These are really general topics for everyone. Tobacco, avoid it for sure. Try to keep your health insurance, keep going to your doctor when you need to, remain active, try to maintain a healthy weight, and, trying to eat well and limit alcohol. So those are general comments, I think, for all people, not only CLL, CML patients. Patients do face lots of different struggles as they, deal with cancer and treatment. And so depression and anxiety can become pretty common. Usually it's after somebody is diagnosed and kind of when things calm down, then patients kind of tend to get depressed in a fair amount of the time. Patients who are depressed will, lose hope. They feel like loss of control. Living with the unknown becomes quite scary. And then isolation and loneliness can also occur. For CLL, patients are living with the disease and sometimes have worry about not treating it, or it's going to get worse, or what I'm feeling is related to CLL or not. Watchful waiting can be challenging for lots of patients. I think some patients really just want to get treated and get it out of get rid of the concern about CLL, and then trying to kind of put it into I'm living with this and not and trying to accept it is hard. But it's really, if you can get to that point, that's the best way to get to it. CML is kind of the same things. There's really not a lot of difference in this. They just list different things. So yeah, the uncertainty or the unknown, educating yourself and being informed really helps. Just recognizing there are some things you can control and not control. Fear and trying to accept our challenges for cancer patients for sure. And then trying to talk to a counselor or a friend can really help help relieve those feelings. If it ever becomes real significant, then medical professionals and behavioral medicine is really helpful for it as well. Let's see, it's kind of a little bit more of the same. So the support that you get from cancer support communities is remarkable. We continue to have you rely on their services as well for individual and group. And then these are some of the information which most of you likely are aware of since you're in this talk with me. And then I'll stop here and see if you have any questions.
We have a comment in the chat. It says this information was really helpful in understanding the rationale behind the watchful waiting, particularly when the patient is someone other than yourself or in your immediate family and isn't present with the doctor's appointments.
Yeah, that watchful waiting again. I probably get more. I probably get more second opinions for CLL than a lot of other cancers, and it's really that patients just look at me and they don't trust what I'm saying, and so when they hear it twice from somebody else, then it kind of makes it real, and it makes it like, okay, maybe I do have a cancer or leukemia and I don't need treated. So hearing that more than once is usually really helpful, because it's a strange phenomena. I view the newly diagnosed CLL patient as like, hey, this is good news. We don't need to do anything. But I also totally understand the fear of being told you just have cancer and leukemia and you're telling me you're not treating me. So and family members and who are not in the room to hear the explanations, it can be really challenging. The information is hard. I would also say typically patients, when I tell them the first time or I'm talking about it, in my other company, the Dr. Who Explains, we we call it the whiteboard, and it's not an offense, but we know that anxiety and will inhibit memory. And so when patients get told they have cancer, they typically just go blank, and we just kind of erase the whiteboard. I can sit there and talk for 30 minutes about it, and they walk out hearing almost nothing. They just heard I have leukemia, and then they hear you're not treating me, and then they go, what? So yeah, I think it's one of the most challenging conversations in a realm of good. So I'm always happy. I'm like, oh, I don't need to treat you, and you don't need to have the side effects, and you don't need to pay $20,000 a month for your drugs and things like that. And the patient's going, well, why aren't you treating me? So I don't know if that's been your experiences, or I'm sure everybody's at a different time point in their journey, but yeah, I get a lot of second opinions just for that reason.
I actually brought that up because we have a relative who was diagnosed with CLL, but I personally had gone through breast cancer treatment with a really aggressive form of breast cancer. So in my case, that cancer was treated aggressively and very quickly.
Yep.
And so it's difficult to understand when you're not part of those other conversations. So this has been really helpful.
Yeah, I would agree. I mean, I think that's what's really hard for most people or patients to realize is, there's at least 450 different types of cancer. There's now thousands and thousands of treatment. And, the generality of I have cancer has really very little meaning to any specific patient anymore. So the big C or the cancer is just not really relevant. The other thing I think is really hard is, when people go look on the internet, they could be looking at the completely wrong disease, and or trying to look up something that's not even, associated with them. So like in your experience, yeah, absolutely. For breast cancer, I mean, we treat it very aggressively in lots of cases. And, so not treating it is something that's, I think, difficult to grasp. It's recommended, and it's definitely the right decision for, not to treat it. Medically speaking, it's absolute right not to treat it unless there's reasons to. But I think it's hard for patients, at least initially, to swallow. But I think as they grow with it, and what I do is I tend to see patients more frequently at the very beginning. So I'll see them, 6 weeks after, or and then 3 months, and I kind of reassure them more frequently in the first 6 months to a year than as they get adapted or they start accepting, like, hey, I'm feeling fine, the CLL is not doing much. Then they just come in and we talk about my kids. But anyway, any other questions? I've got another meeting to jump to as well. And so great. I'm glad.
I want to say thank you to Dr. Joe for sharing his time and his expertise with giving us this presentation. We do appreciate you guys hanging in with us as we had rescheduled this session. So thank you very much. And Dr. Joe, I know you have another meeting, but if you could hold on just one quick second.
Yeah, sure.
I have some information to share with you.